following episode is brought to you by the American Urological Association. This episode features content from the AUA2026 meeting in Washington, D.C. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. Support for this activity has been provided by an independent educational grant from Pfizer, Inc.
All right, morning everyone, and welcome. Welcome to our course on muscle-invasive bladder cancer. This is presented by American Urological Association and sponsored by Pfizer. However, this is an American Urological course. The AUA strives to offer outstanding educational courses and greatly appreciates your evaluations after this so we can continue to improve on our existing courses. In terms of faculty that we have today, I'm Dr. Bukovina. I'm a urologic oncologist at Cleveland Clinic. We also have Dr. Adam Calloway, who's a urologic oncologist at Case Western, Dr. Sam Haywood, who is a urologic oncologist at St. Louis Urology, Dr. Shalini Manindi, who's a radiation oncologist at Cleveland Clinic, and Dr. Abhishek Tripathi, who's a medical oncologist at City of Hope. So we have a nice representation of what we call a multidisciplinary team to talk about not only our evolving MIBC space, but also, we'll go over some cases as well as participation from the audience to see what currently is being done, not only in the academic setting, but also in the community setting, which is incredibly important. Course evaluations will also be available at AUA2026 website. Again, they're very important. And also, if you are claiming CME, remember this is a free registration and you can get free CME. Please claim them through the website. Without further ado, we'll get you talking.
Good morning, everyone. Thanks so much for the invitation, Dr. Bukovina, to this exciting session. All right. Good morning, everyone. These are my disclosures. My main disclosure is that I'm a medical oncologist. So at this meeting, I'm inclined to think about things more systemically, more broadly, and hopefully that'll be reflected in our discussion today. So we are very well familiar with the data on cisplatin-based therapy that has been demonstrated across several trials, meta-analyses, and has remained the standard of care for the past 20 years or so, I believe, from the early trials. The overall survival benefit was of the order of 5 to 10% at around 5 years, and that informed a lot of the discussion, and also something we discussed in terms of like eligibility for chemotherapy and so forth. But the utilization of cisplatin-based therapy has been relatively low, and it has picked up over the past several years, but in the grand scheme of things, it still has remained underutilized. And part of the reason is that a lot of our patients that we take care of are ineligible for cisplatin due to their comorbidities and renal function and so forth. Then there is perceived limited effectiveness of the systemic therapy with pathologic complete response in the 30%. A lot of the patients don't respond to it and have disease progression, so that limited its utilization. Then treatment preferences from patients. Some patients don't prefer to undergo chemotherapy before. They want to proceed with with surgery directly. And then lastly, there can be significant barriers to accessing multidisciplinary care, especially across in the community setting. For patients who do not undergo systemic therapy or cisplatin-based neoadjuvant therapy, we know that the outcomes are extremely poor for those patients. And vast majority of those patients have disease recurrence or death within 2 years. And that's been the traditional treatment paradigm that we have been working with. The EV303 study aimed to actually change that paradigm. So this was one of the first studies that was specifically looking at systemic therapy options in cisplatin ineligible patient population. The eligibility criteria for the patients were patients with MIBC T2 to T4 disease. Node-positive disease was also allowed. Patients had to have urothelial predominant histology, and cisplatin ineligible based on the Galsky criteria. The patients were randomized to receive directly cystectomy followed by observation or surveillance, which would be the standard of care for these patients, or receive EV and Pembro for 3 cycles up front, and followed up with radical cystectomy, followed by adjuvant therapy with EV and Pembro. The EV in that case was for approximately 6 cycles afterwards, and pembrolizumab was continued for 14 cycles total. These are some of the baseline characteristics of the patients. On the left, you can see it reflects a lot of our patients that we see in the clinic every day. Patients were older. They were cisplatin ineligible, with GFR being the primary reason for being cisplatin ineligible. And a lot of these patients had high-risk disease with T3 and T4 disease patients, or node-positive patients, summing up a good chunk of the patients included in the study. Across the two arms, about 170 patients were randomized, and about 144 in the experimental arm completed the neoadjuvant therapy component of it. Out of those, most of those patients were able to undergo surgery, and interestingly, the cystectomy rates were relatively similar between the surgery and the neoadjuvant therapy arms, indicating that neoadjuvant EV-pembro did not compromise the ability to undergo definitive local therapy, even in this poor prognostic subgroup of patients. Following the surgery, about 100 patients started the adjuvant component, so we can see there is attrition from neoadjuvant to surgery to adjuvant therapy component, and ultimately about 43 of them completed the full prescribed course, with some of them discontinuing due to toxicity or disease progression and other reasons. These are the primary endpoint results of the study. The primary endpoint of the study was event-free survival, and the trial demonstrated a significant improvement in event-free survival with EV and P compared to just cystectomy by itself. At the 2-year time point, the median EFS was 75% in the experimental group, compared to just 39 or 40%, and that kind of reflects the standard of care practice we have seen for the past several years. The hazard ratio was significant with 0.40, and that is somewhat of an unprecedented hazard ratio in this specific patient population. To put this in perspective, we're not going to do cross-trial comparison, but I would like to do cross-trial contextualization, so that at the 2-year time point, we have some data to show us how this data actually compares. So in the CheckMate 274 study, which was purely adjuvant, and similarly in the adjuvant setting, we see a 2-year event-free survival of around 50% or so. So compared to those data, these data look fairly promising with a 2-year DFS of around 75%. This is the overall survival data from the same study. Again, there's a lot of censoring at the 2-year time point, so the data is actually being evaluated right now. The median had not been reached in the experimental arm. And the treatment was associated with significant improvement in overall survival as well, with a hazard ratio of 0.50. Perhaps more importantly, it showed us that how poorly these patients do in the control arm, and the median OS in those patients was only 41 months, less than 4 years. And that really underlines the need for getting systemic therapy up front. The pathologic complete response rate was a significant endpoint for this study. The pathologic complete response rate in the intention to treat population was 57%, whereas about 8.6% of patients had PAD-CRs and cystectomy alone, likely driven by the TURBT preoperatively. However, if you look at the patients who did undergo cystectomy and just use them as the denominator in calculating PAD-CR percentage, that percentage actually jumps above 60%. And those are unprecedented numbers, even if we compare to prior cisplatin-based regimens and trials. Speaking of cisplatin-eligible population, the Niagara trial was perhaps the first trial in that setting in recent years that has changed practice and became the standard of care. As a quick recap, this trial evaluated the combination of cisplatin and gemcitabine with or without durvalumab in cisplatin-eligible patients with muscle-invasive bladder cancer. The interesting and notable thing about this trial was that this trial was designed a lot more pragmatically, and it allowed GFR of 40 or higher to be allowed, which has not been the case in prior cisplatin-based trials. And this reflects some of our practice where patients would receive split dose dosing and dose reductions to manage the GFR issue. As you can see on the bottom, the event-free survival and overall survival were again favoring the experimental arm, and the drug was approved based on the improved efficacy rates. So this represents one of the current standards of care for patients with newly diagnosed muscle-invasive bladder cancer. It is important to note that adjuvant immunotherapy was not a component of this trial in the control arm because adjuvant Nivo data was not available at that time and wasn't considered standard of care. Looking at the EV304 study, this is the trial comparing EV and pembro with cisplatin and gemcitabine in a more contemporary population. The patients had to have muscle-invasive bladder cancer, eligible for cisplatin based on the Galsky criteria, and had urothelial predominant histology. Patients underwent EV and pembrolizumab combination therapy or cisgem for 4 cycles, and this is slightly different from what was done in the cisplatin ineligible cohort. Patients underwent radical cystectomy, and in the experimental arm received continued EV and pembro as part of adjuvant therapy. Again, no adjuvant immunotherapy was included in the control arm because it represented the time that the trial was designed in. These are some of the baseline characteristics, again, very well balanced and reflects our clinical practice. But again, we saw that compared to cisplatin and gemcitabine, EV and pembro didn't really induce new challenges in undergoing definitive local therapy. Again, there is attrition between neoadjuvant to surgery to adjuvant component, but that is somewhat expected given the toxicities and some of the patient characteristics that enrolled on the study. These are the primary endpoint results. So this is event-free survival. And again, we can see here the event-free survival strongly favored EV and pembro compared to cisplatin and gemcitabine, with around 80% of patients remaining free from recurrence compared to 66%. For context, in the Niagara trial at the 2-year time point, about 66% of patients were event-free, and similar in the Vesper trial comparing dosed-in-Zemvac and Gemcis, again, 66% of patients. So these results do look favorable even in the context of prior cisplatin-based trials that we have done so far. These are overall survival results. Again, a lot of censoring at the 2-year time point. I think we need more longer-term follow-up, but initial readouts are very encouraging with a hazard ratio of 0.65. And as we get more events in the experimental arm, we'll be able to get a sense of how these patients do in terms of overall survival. The pathologic complete response rate was very similar to what we have seen in the cisplatin ineligible cohort of around 56%. Again, if you look at the patient population that underwent cystectomy and only used that as a denominator, that number probably goes above 60%. The PathCR rate in cisgem arm actually reflects very closely what we have seen with several other studies and in clinical practice of around 32% pathologic complete response rate. So very similar to what we have seen in other studies. This slide summarizes the hazard ratio and PathCR rates across these trials. As you can see, we have made significant inroads into better efficacy through systemic therapy. The PathCRs have gone from mid-30% to now above 65% in some of these patients, and the hazard ratios are now strongly favoring systemic therapy compared to cystectomy by itself, even in cisplatin ineligible patients. As it stands, we have 2 regimens that have shown overall survival, disease-free survival benefit with promising overall survival data in the cisplatin eligible subset. Cisplatin, gemcitabine, and durvalumab remains an approved regimen, and there are certain considerations we need to take into account when thinking about which regimen to choose outside of efficacy. The cisgem durva, again, we have to think about GFR cutoffs. The Niagara trial allowed for GFR of 40 or higher. So for somebody who's got a GFR of less than 40, that regimen really becomes difficult. Other cisplatin ineligibility criteria continue to apply, so that peripheral neuropathy, heart failure, performance status, those are all contraindications to cisplatin-based neoadjuvant therapy. On the other hand, we don't have well-established contraindications precluding EV and pembro therapy at this point. And the reason is the risk-benefit ratio of overwhelming efficacy versus the relative side effect profile we can manage quite effectively in the clinic. Peripheral neuropathy is a relative contraindication that has been very effectively managed in the clinic with dose reductions, dose holds. And I think if you're able to get some neoadjuvant therapy, albeit with dose reduction, I think that still should offer some benefit to the patients from a systemic disease control standpoint. An interesting point that comes up with EV and pembro management is that diabetes or hyperglycemia. So that is actually something that needs very close monitoring. Hyperglycemia is a known side effect profile of EV monotherapy. We have seen in EV302 trial, and also continues to be that case in the muscle-invasive setting. So it really requires multidisciplinary treatment, and in the clinic, we are usually working with our colleagues in endocrinology or the patient's primary care physician to have a solid roadmap for how to manage the blood glucose levels closely. Contraindications to both regimens, and these are actually shared between EV pembro and cisgem durva and are likely driven by the IO component of it. So patients who are on concurrent immunosuppression for autoimmune disease, prior organ transplant patients, they continue to be high risk for IO-based regimens. And in those cases, a case could be made for just platinum-based therapy being the old standard of care because these patients would not have made it to the Niagara or the EV304 studies. Despite these trials that have read out over the past few years, there are several unanswered questions that we need to start working towards. How many cycles of neoadjuvant EV pembro is enough or ideal? We have seen similar pathologic complete response rates of in the high 50s to low 60s with both of these regimens. At what point should we send the patients back to surgery for definitive local therapy? Is there additional biomarkers that can help us tailor how much neoadjuvant component we're using? Could patients achieving MRD negativity early on with 3 cycles could go on to surgery sooner? I think that's something that we need to answer in the forthcoming studies. Do all patients need surgery? I hate to ask that question, but it is a dangerous question to ask because the patients are asking that question. Because when we talk to our patients about a path CR rate of 60%, we're not going to be taking out the bladder and not finding any cancer in 60% of those patients. We are usually the ones reviewing the pathology report with them, and we have to explain why surgery is still an important role as part of the treatment. And I think we need to study that more prospectively to actually individualize both the systemic therapy and the local therapy component of it. How do we apply these results to trimodal therapy? As was included in some of the pretest questions, there are studies that are ongoing to see if we can adapt some of these regimens and use them in the context of trimodal therapy. This WALK-BRIGHT trial is one such example where patients are able to get immunotherapy and radiation therapy after EV pembro-based neoadjuvant therapy. And then lastly, can we individualize the adjuvant component based on response, or I would say lack thereof? I think we talk about the 60% of responders, but then there is 30% of patients who do not achieve a pathologic complete response in downstaging, and I think we need to really understand how to best treat them in the adjuvant setting after surgery. To conclude my talk, EV and pembro have significantly changed the treatment landscape for both cis-eligible and ineligible patients. Multimodal therapy and multidisciplinary care is crucial now more than ever to achieve the best oncologic patient outcomes across the bladder cancer spectrum, including both cis-ineligible and eligible patients. And ongoing studies will help us answer the lack of data in the trimodal bladder sparing space. With that, I'd like to end the talk. Thank you so much for your attention, and I'll give it back to Dr. Bukovina.
We're going to do a case-based discussion and questions based on everything that's been presented at the very end. We have some interesting cases, but we're going to go ahead and move on. Dr. Adam Calloway is going to talk about surgery within these patients. And then can we also make sure we start the timer? It wasn't on last time. Thank you.
I don't see. Oh, got it. Are you picking it? Did I not open the right one?
It's the right one. That's fine.
This is me. All right, so we're going to talk about bladder preservation and consolidative therapy in the era of enfortumab vedotin and pembrolizumab, identifying the right patient and the right timing. These are my relevant disclosures. And I like to think of the EVP era. We just heard how great it is and how this has monumentally changed the way we manage muscle-invasive bladder cancer as the next frontier. These were the first major changes in muscle-invasive bladder cancer that have benefited our patients over decades. But I think some metaphors for my talks, different metaphors, are a little bit more apropos. So I think bladder preservation with systemic therapy has been akin to the Wild West. We are already having these routine conversations about challenging our guideline-based therapy because of the wonderful results in EV303 and EV304. And this is really leading us to considering operating or providing localized therapy less for localized disease, which is contrary to oncologic dogma. Contrary to that is consolidative treatment, and this is uncharted territory. And because of the results of EV302, where metastatic patients are living longer and being in complete response, should we offer them more operations on more advanced disease and less systemic therapy? And we have a lot of questions to answer. And this is the real world. This is rapidly changing, and there are absolutely no clinical trials or prospective data to guide us on this, and it's driven by both us as providers and especially our patients. And the goals and perspectives are different in each setting. So let's talk about bladder preservation in relation to only systemic therapy. And we did see the EFS curves of EV303 and EV304, but the EFS benefit of perioperative ofatumumab vedotin and pembrolizumab is fully dependent upon the receipt of surgery and adjuvant therapy. So why would we ever consider taking those away? Well, it's because the secondary outcomes, which were already shown, is the path CR rates are magnificent. So if 50 to 60% of patients are path CR, does this really question, do we need to take these bladders out? Do we need to continue on their systemic therapy? And why are we asking that question? Well, there's two reasons. So previously, path CR rates, based on whatever neoadjuvant regimen you want to give, was maybe somewhere between 20 to 35% conservatively, and now that is different, up by 20 to 25%, where the majority of patients are disease-free. The second thing that was already alluded to is this is predominantly cisplatin-based therapy in the previous regimens, of which 50% of patients could not get. Now I find it very rare for our medical oncologists to say no to ofatumumab vedotin. So everybody, and pembrolizumab, everybody can get those. So this obviously leads us to hypothesize, well, cystectomy, we all know, is perhaps morbid and not desired in many, and our previously path CR rates were low. But now they're better. And we know that pathological complete response correlates well with RFS and OS. And if we can hit high path CR rates, can we avoid cystectomy in all patients, in many patients, or the majority? But we have some questions that we have to answer. And I think this is the biggest one, and it's been talked about every day of this meeting, is a clinical complete response the same as a pathologic complete response? And going forward, is a pathologic complete response a good surrogate for overall survival? And I think there are some issues with clinical complete response, and this is just one paper from the Fox Chase group, which basically compared clinical complete response and then took out their bladders. And you can see here that 25% of patients that met criteria for clinical complete response still harbored muscle-invasive disease. When looking at the ability of clinical complete response to predict those patients' absence of disease, it was less than a coin flip in accuracy. So I think that this all talks about the lack of ability of our tools to predict those who don't have disease. So you can see whether it's cystoscopy with biopsy, cross-sectional imaging of any variety, or cytology, they all perform fairly poorly with wide-ranging sensitivity. MRI may be the best, but that's totally dependent upon the protocol that is done and the reader in the center that it's done at. There's obviously some very interesting data out there about newer biomarkers, ctDNA and urinary tumor DNA, and how those may be able to help predict those that have disease and those that don't. But there is some caution. So at GU ASCO this year, ctDNA in the retained bladder cohort showed a relatively poor sensitivity of detecting those that had active disease, meaning it was often negative, but disease was still present in the bladder. So I think there is more to come on those biomarkers. This segues nicely. What do we do with this retained bladder? Say we do not remove them. Well, this is the retain 1 cohort. About 25 patients were able to retain their bladder that met criteria for clinical complete response. Few remained NED. Many of them recurred. Many of them, about half of those that recurred required a cystectomy, and about half of those that recurred actually recurred with metastasis, often in the bladder first. What I think that this tells us is that 1, recurrences are common, and 2, we need to look for them. So we need to both monitor the bladder and outside of the bladder to try to find them and find them early before it causes harm. And then we have to say, well, preservation at what cost? And there are certainly uncertain strategies, and that we need to refine that, and we need to look at our trimodal therapy cohorts and say, this is probably how we should mirror our surveillance. So when should we do cystoscopies? When do we do biopsies without cause? What imaging should we use and how often? I think we really need to get some consideration of patient-reported outcomes. Can we do a study similar to the Cysto trial in non-muscle invasive disease to say, is this something that the patients actually prefer? Or is all of this surveillance also a burden? and the utility of new biomarkers. And certainly all of this surveillance can lead to increasing monetary costs and patient anxiety. And the other thing is are we just trading systemic side effects, which sometimes don't go away, versus the surgical side effects, which we all know well about? Obviously, this is the biggest proposed trial, and nobody, to my knowledge, is enrolled in this, but this is EV209. This is a single-arm, 240-patient study of localized bladder cancer, and their goal is to treat with ofortumab vedotin and pembrolizumab for 9 cycles. Primary outcome is clinical complete response and bladder intact-free survival, and there's a lot of discussion on the social media networks. And I'd like to highlight Dr. Bukovina's appearance on this podcast if you want to hear more, and we'll sure to talk about that later. We're going to skip over EV prime. So who to do this for? The right patient, the right timing, we really don't know, but it's obviously the patient that doesn't have cancer within their bladder that's never going to recur, and we just can't predict that. But this is already into our practice. It's already leaked into our practice, and why do we have that appetite for that? We're planning prospective trials, but can we do randomized trials? And that's probably just not going to be possible because you're randomizing to surgery versus not. We need to answer questions. So let's shift gears for just a little bit on consolidative therapy. And there is some historical context to this. So these are the most widely cited studies about providing surgical consolidation in those with locally advanced or metastatic disease. So these were small, single-center, retrospective, heavily selected patients in the chemotherapy era. And what they came up with is that you could still get path CRs in this. And there seemed to be an oncologic benefit in this very appropriately selected patients. But we all have to remember this was in the chemotherapy era. And prior to ofortumab vedotin and pembrolizumab, the median OS of a metastatic urothelial carcinoma patient treated with chemotherapy was 20 months, and about 5 to 10% of patients lived for 5 years. With EV302, that's changed. So the median OS is now double, and about 40 to 50% of patients live at 3 years, which leads us to a treatment dilemma. You have these tails of the curves that are flattening out, and they're on per 302 therapy until they can't tolerate or a decision is made to avoid it. So since our outcomes appear to be durable and our patients that perhaps are responding are higher, what is the role of EVP until progression or toxicity, and is there an expanding role for a local consolidation? And there is some data on this. This is in NCCN guidelines about consideration of consolidative therapy in M0 or M1 who are unique responders. But what patients and when do we choose to offer this? Well, that's expert opinion at this point in time. So obviously the patient with local symptoms, with obstruction, with nephrostomy tubes or stents, hematuria or pain may be great. Perhaps disease characteristics, nodal burden, probably better than visceral disease. The number of sites should be lower. We also have to consider the cost of care. EV Pembro is very, very expensive, both financially, monetarily, and with toxicity that doesn't go away, especially with neuropathies. And then we have to think about what our risk is with our knife. Is there a quality of life trade-off? Is there complications, obviously, with cystectomies? So who do we consider? Healthy patients, surgical candidates? This is obvious. Partial response at least, or a dramatic response. And we want to try to pick the patients with the residual cancer. Some of the other disease-specific factors are listed there and previously mentioned. And all of these patients, if you're considering this at your center, should obviously be talked about in multidisciplinary settings. When should we do it? Well, the response to EV in Pembro is dramatic and it is early, and that's known by EV103, where you can see that most of the timing to first response or clinical complete response is within the first few months. So many of the studies that I'll allude to in just a moment, they're looking at 4 cycles of EV Pembro prior to considering consolidations, which is drastically different than the 9 that is planned for localized disease. What's known about this? Well, there are 4 recently published and or submitted papers looking at consolidation after EV Pembro for locally advanced or metastatic disease. A little less than 100 patients, so not that much. The median cycles of EVP was anywhere from 4 to 6. Remarkably, about 50% of patients can still have pathologic complete response, and many of them, if they're not completely responding, are downstaged. The argument here is that that many of these patients then went off of therapy. So they use their pathology from the time of consolidation and use that as justification to go off of it. Whether you're okay with making that leap or not, that is still left to be determined. But we're giving 6 cycles for advanced disease and perhaps more for localized, and that's something we certainly need to think about. And even despite all of this, there are some people that recur and some people that die, although small in numbers. So there are some enrolling trials, both in the surgical space on top, looking at 4 cycles of EV Pembro followed by surgery, and in the radiation space. And we look forward to seeing what those have to say to drive our further plans. So in general, we have a changing population, I think, of patients undergoing cystectomy. Maybe a little less localized over time, perhaps, maybe a little bit more advanced. And is that right? Well, we have no idea, but it's already into practice with very little data, and we have to be smart about how we make these leaps of faith. Single-arm prospective studies are planned. Can we do randomized studies? That would be great. I don't know, but many questions still need to be answered. Thanks.
Thank you, Dr. Calloway. That's a great overview. We're going to move on about radiation treatment. Dr. Shalini Moniji will talk about radiation treatment in EVP era for the patients.
Oh, okay. I don't know if the new one was uploaded, but that's okay.
You reset the clock. Thank you.
Okay, perfect. Well, thanks everyone, and thank you all for joining us at one of the last sessions here at AUA, and I want to thank Dr. Bukovina and all the organizers here for having me. I'm a radiation oncologist, and I specialize in bladder cancer at Cleveland Clinic, and today we're going to talk a little bit about the role of radiation treatment and specifically trimodality therapy, and go into some data, how we've evolved with radiation so far, and what our standard of care is now, and what the current trials are in the landscape. I have no disclosures, and I'll follow up with our medical oncologist here that I am a radiation oncologist. So in terms of standard of care, for muscle-invasive bladder cancer, right now we have 2 treatment options, which include either neoadjuvant systemic treatment followed by a radical cystectomy, or TMT or trimodality treatment, which includes a complete TURBT followed by chemoradiation treatment to the entire bladder. Now, just a little bit of background of where we were and where we are now. So in 2013, bladder preservation treatment, or TMT, was actually a Category 2B recommendation. And we were still mainly doing preoperative systemic treatment followed by a radical cystectomy. And fast forward more than a decade later, last year, now TMT is actually a Category 1 recommendation for patients with muscle-invasive bladder disease. And so when we think about TMT or chemo-RT for bladder cancer, we think about it in the muscle-invasive setting. We also consider it in the node-positive setting, where we treat the nodes and the bladder. And for more advanced disease, such as clinical T4B disease, we consider consolidative chemo-RT after initial initiation of systemic treatment. And we'll go into that in a little bit. So what is a paradigm for TMT? Patients get a maximal safe TURBT, and then they undergo radiation treatment to the entire bladder, along with concurrent chemotherapy. And then following this is surveillance, which is basically cystoscopy and imaging every 3 months. Now, if patients recur on cystoscopy or imaging, they would get a salvage cystectomy. Now, and I'm going to go through a little bit of a history of where we were and where we are now. So eligibility for patients that are going to undergo TMT. So you have patients who have T2 to T4 disease, ideally node-negative patients who have really good bladder function because they're keeping their bladders. Patients who don't have hydronephrosis are patients that we do tend to prefer, and patients who do have hydronephrosis, if that's something that could be fixed, we would consider it after that. And like Dr. Calloway mentioned, multi-D evaluation is really critical. These patients, a lot of them are not the healthiest of patients, and we really want to consider their entire picture clinically before we pick the right course of action. Now, in terms of concurrent chemotherapy with radiation. Cisplatin-based chemo is something that's tried and true that we've used for quite a bit. So that's 5-FU mitomycin or gemcitabine. And radiation dose traditionally was always conventionally fractionated, so 60 to 66 gray and 2 gray per fraction. So that's about 32 treatments of radiation, so about 6 weeks of radiation. 3D radiation treatment, which I'll go through in a little bit with the trials that I'm going to present, that's sort of our old-fashioned radiation treatment, where we're not carving radiation dose from small bowel and other organs at risk. We now use IMRT traditionally across all trials and also just in practice. And there was also an initial split course that was used at MGH, and now there's a continuous course chemo-RT that we'll talk about in a little bit. And one thing to keep in mind is in some of the original studies that we have, like BC 2001 and some of the TROG trials, there were not that many patients that actually got nodal radiation. So the majority of these patients just got whole bladder radiation treatment along with concurrent chemotherapy. So I want to first start talking about fractionation of radiation treatment and then a little bit about concurrent systemic treatments. So like we had mentioned before, we started out using conventional fractionation. We still use it now. This is 30 to 32 fractions where patients get radiation to the entire bladder. Now, there was a large meta-analysis looking at patients from the BC 2001 trial and BCON trials and basically investigating whether we can hypofractionate these patients. So take the same amount of radiation dose and squish it into 20 treatments or 4 weeks. Do these people do the same in terms of outcomes, and how is the toxicity profile? And what we found was that 55 and 20 was actually non-inferior. Some of them did quite well in terms of local regional failure, and the overall quality of life and patient-reported outcomes was wonderful. So they did great, and so, current radiation trials, you'll notice that 55 and 20 are tried and true regimen for hypofractionated radiation treatment to the bladder. Now, I know this is a little bit of a risque slide at AUA, but how does RC and TMT compare? So, like Dr. Calloway mentioned, unfortunately, we don't have a lot of head-to-head, or actually no head-to-head, prospective trials. So we have some retrospective analysis comparing patients who've had a radical cystectomy and TMT. And as you can see with all of these curves overlapping, similar MFS and cancer-specific survival rates long-term. Now, there's a huge caveat here, right? Who are patients who are ideal for TMT and who are patients who are ideal for cystectomy? And I think that's where the multi-D evaluation is critical. And, that's where there are some unanswered questions as well. What's happening? Okay. So who is an ideal patient for bladder preservation therapy? And these are a couple things to keep in mind. First of all, unifocal disease would be great. We still treat patients with N1 disease, but when you think about N1 disease, you want to consider the bulkiness of their lymph nodes and what their response is if they're having upfront chemotherapy or upfront EV-pembro. Maximal TURBT is super important for us. Unfortunately, when patients don't have a complete TURBT, that is a really poor prognostic factor towards how they respond to chemoradiation to their bladder, regardless of what dose we give to the bladder. Extensive CIS is also a poor prognostic factor. Hydronephrosis, like was mentioned before. Good bladder function is super important because these patients keep their bladders, and their quality of life is very much dependent on their bladder function up front because that's sort of the baseline before they dip a bit when they get the radiation. And then variant histology is a very interesting question. There have been a few studies that are institutional data sets looking at variant histology and chemo-RT, showing some benefit with chemoradiation as well in terms of local control benefit. But the data is still murky in terms of variant histologies. A lot of these trials don't have a lot of variant histologies. So that's something to consider and really pause before considering TMT for these patients. And so this is a really great slide that one of my colleagues actually came up with, Dr. Mao. And so this just really gives a good idea of when to consider TMT versus RC. So you think about people with the poor bladder function, inflammatory bowel disease, prior radiation treatment, things that really are contraindications for radiation to the pelvis would be wonderful, obviously RC candidates. And then people who are really not great surgical candidates, of course, would really benefit from TMT. And then we also have this population of patients who really want to preserve their bladder. And I think that's the population that we really need to think about and the criteria that I just reviewed to make sure that they're ideal patients for bladder preservation, that they respond well to it, and that we're not putting them down a path where they might need a radical cystectomy down the line. And so we talked a little bit about fractionation, the 32 fractions versus the 20, and to talk a little bit about split course versus continuous course. So traditionally, some of the original trials and data from MGH and Boston looked at chemoradiation treatment in a split course fashion, meaning patients would undergo a complete TURBT, start chemoradiation, and then midway through chemoradiation would get a cystoscopy. If they had residual disease, they would just go directly to a radical cystectomy and not complete treatment. However, now we've transitioned to continuous course chemo-RT. So you have patients who will get a complete TURBT and then complete their entire course of chemo-RT, which is usually about 20 fractions, and then get monitored with a cysto and imaging. And I want to now touch on the BC 2001 trial. So this trial, the main goal of this trial was to actually investigate whether concurrent chemotherapy was necessary in addition to radiation treatment to the bladder. And they actually found that it was necessary and it improved local regional control rates. But what was also interesting about this trial is they played around with different radiation regimens. They also played around with what needs to be radiated. Do we need to radiate the entire bladder with this high dose? Can we just focus on the area where the tumor was and give that area a high dose of radiation? And so this is a little bit of a complex slide, but you can see that they had different versions of radiation fractionation and then the amount of bladder that was radiated. And basically what they found was that 55 and 20 is equal, and in some cases could be slightly superior to the 64 and 32 fractionation regimen. And what they also found was that we really need to treat the entire bladder. Treating just part of the bladder with high dose is not sufficient. So that's really helpful as we're creating and running these new radiation trials that we treat the whole bladder, we hypofractionate, and we treat nodes if necessary. And this is just these are some curves from the BC 2001 study, just emphasizing the role for chemotherapy along with radiation treatment. And so now I want to just touch on some current trials, and our wonderful medical oncologist talked a little bit about the SWOG study, the SWOG-BRIGHT study with Dr. Ballas. And so this is going to be really interesting to really see how patients do in a consolidative perspective. So with EV Pembro, patients who are eligible for the study can have T2 to T4 disease that are N0, and they receive up to 3 cycles of any kind of neoadjuvant therapy. And if they have a good response and have either T0 or T1 disease on repeat TURBT, then they are eligible for the study, and they basically get the 55 and 20 hypofractionated radiation treatment to the bladder with concurrent pembrolizumab. And this is followed by surveillance with cystoscopy and imaging. So this is actually the first trial after the EV Pembro studies have come out, where we can actually start investigating what the role is of TMT in the consolidative setting after neoadjuvant systemic treatment. So we're very excited about this study and hope to see what this really shows for our patients. Now, another study I do want to also put a plug in for is the NRG Archer study that actually looks at hypofractionation for radiation treatment. So we talked a lot about how we've kind of squished from 6 weeks to 4 weeks of radiation treatment. Now we're actually going to be investigating SBRT to the bladder. So that's 5 fractions of radiation treatment to the bladder instead of 20. So one of our radiation colleagues, Dr. Nagar at MSK, is leading the study nationally. And we're really excited about this because our hope is that if this can be equivalent from a disease control perspective and a quality of life perspective, that would really be wonderful for a lot of our patients and would also improve access to care for a lot of patients that are coming from the community. So I want to also finally touch on post-op radiation treatment for bladder cancer and what the role is. So we don't really know, but there's been some new data in this space. So for patients with high-risk disease post-radical cystectomy, as we all know, there are higher chances of local recurrence. And this is for patients that are, PT3, T4, and then also have a positive margin. So I just put this slide up here because I thought it was really important for the urologists in the crowd to get an idea of what we're treating as radiation oncologists. So this is the pelvis post-cystectomy. So when we're treating patients in the post-op setting, there's a bunch of bowel. So that brown line is the whole field that we treat with radiation. So we want to be very cautious on the types of patients we're offering adjuvant radiation to. So we really want to pick these high-risk players that are going to benefit from local adjuvant treatment. And so I just want to touch on the BART study, which was presented a couple years ago at ASTRO, looking at 153 patients with high-risk disease. So these patients had PT3 or PT4 disease and one disease, positive margins, or a clinical T3 or higher disease up front. And they were basically randomized to observation or adjuvant radiation treatment. Now, 50.4 gray is sort of our prophylactic dose. It's enough to kill off microscopic disease. So that's what these patients got. And, as radiation oncologists, what we were most worried about actually was toxicity more than anything. And these patients had very reasonable grade 2 GI toxicity and very limited grade 3 toxicity. And there was a benefit from a local regional control perspective when patients did get adjuvant radiation. So this is something that we're starting to consider in the adjuvant setting for very high-risk players. And I just wanted to put in a little bit of a plug for NMIBC as well, and considering radiation treatment for high-risk T1 disease. And then I'm just going to conclude. So, overall, I think we've transitioned and really evolved in the radiation space in TMT. We're starting to use hypofractionated radiation treatment in 20 fractions. We have trials looking at even SBRT for TMT or bladder preservation treatment. There is an increased role for adjuvant radiation treatment for high-risk MIBC. And in terms of biomarkers, there is more to come, but for all of these trials like SWOG and ARCHER, we're starting to get ctDNA and urine DNA. So we're going to learn a lot about, patients who might be ctDNA positive or negative and whether we can dose escalate or de-escalate treatment. So thank you all.
Thank you, Dr. Meningi. And we're going to finish off with Dr. Sam Haywood from St. Louis Urology and his take in terms of community urology practice and how everyone is adopting to EVP and cystectomy versus bladder preservation with radiation. Take it away.
Thank you. And as everyone has said, thanks for Dr. Bukovina and the organizers for putting this all together. So I'm going to be talking about kind of how we do this in the community setting. My conflict of interests are none. I will say, however, my one caveat here is that I did spend the first majority of my practice in an academic center and have recently moved into community practice. And so I've had to do a lot of mental shift and sort of how do I do this in a different setting in the last year. And so I'm trying to share some of that experience here. It'll be a little bit of a different talk. There's going to be no Kaplan-Meier curves in here, but it'll be more of kind of a practical talk of how do I do this. So why bladder preservation? Well, of course, not all patients want to lose their bladder. I actually, as I've shifted into a little bit of a different patient population, I've had more and more patients telling me that. In a lot of community settings, there's limited access to qualified surgeons, and I want to clarify here, I don't mean qualified as in community urologists are not good. It's just that there's a lot of community practices that are not able to do cystectomies in a less resource-heavy environment. And many patients are suboptimal surgical candidates. Now, you see that both, of course, in the academic and the community setting, but there are a lot of patients that are not optimal surgical candidates. And on the flip side, we know that there is comparable survival. We just saw some excellent data on this. I have the asterisk here of the well-selected patients of who is that? We still don't really know, but we know that there are well-selected patients that can do very well with bladder preservation. And of course, there's been a lot of data presented at this conference about the quality of life gains by keeping the bladder. And so why do we talk about TMTB in the community? So as I mentioned, many patients are not ideal cystectomy candidates. We've all seen the slide of the T2, unifocal, all of that. I think both academic and community practice, we know that most of those patients are not ideal cystectomy candidates. A lot of patients refuse or are unable to obtain care at a tertiary center. I see this a lot, and my main practice is in St. Louis, but I do a fair amount of outreach at a community about 30 minutes outside of St. Louis, and there are patients that will literally tell me that they will never, on any circumstance, go into the city. And so had to change a little bit of the idea of these patients will not travel somewhere to where they could do a cystectomy or get care at a tertiary center, and so have to sort of figure out a way to bring the best care that you can to them. As community urologists, the goal is to maximize our initial TURBT, whether we're going to be treating them ourselves or referring them to a tertiary center. That helps everybody by maximizing that first surgery. And then finally also setting patient expectations. For those of us that have been, for those providers that have been doing this for a while, for a long time, the cystectomy was the only way that we were managing these patients. And so, I used to get these patients referred for a cystectomy and had never heard about radiation. So that's one way that in the community we can really improve and sort of set expectations for patients. So what are the components of bladder preservation? No, this is not new here, but I want to make a couple comparisons here. It is the trimodality therapy. It's not radiation alone. And so when I start the conversation with patients, I have to be very upfront with them and saying, look, this is not a quick, we're going to do radiation, then we're done. There's several components to this treatment. It is treatment with curative intent. We're not doing palliative care in most of these circumstances, and that's another distinction that I have to be very upfront with patients about, because a lot of them think, well, if we're not taking the bladder out, are we just kind of just letting it stay there and kill me? And so have to be very upfront with them that we are treating them with curative intent. And then finally, I tell these patients, this is the start of a therapeutic relationship. This is not one and done. So we're not just radiating the bladder and then, running away. We have to do a very close surveillance and keep track of things, because there are patients that recur, as we've seen in several of the talks here. And so the components of bladder preservation, we're doing, the maximal TURBT, and I'll look at some data in a minute for that, concurrent chemo radiation, and then finally the close surveillance. And so starting off with the complete TURBT, here's several studies looking at the benefits in trimodal therapy of doing the complete TURBT up front. Those patients, have a higher, complete response rate, and those patients do better. And then I have to include in here, the kind of famous Harry Hurst study of TURBT alone in selected muscle-invasive bladder cancer patients that had a great, overall survival. Of course, that's a very, very, specific population, but I think it lends, credence to the idea that how important that initial, complete TURBT is. I'll race through this because we've talked about this a lot today. But these are really the kind of the ideal and contraindications. But as we talk about in the community setting, a lot of the patients are not ideal candidates. And so, where it would be ideal if you could say you're not a great candidate for trimodal therapy, you should really consider a cystectomy. As I mentioned earlier, some of these patients are unable or unwilling to travel, and so you really have to consider the fact that you're treating a not ideal candidate. And that all comes down to the shared decision-making with the patient. You can say to them, you may have, a tumor that's too large, or you might have some hydronephrosis, and you're not the technically ideal candidate for, trimodal therapy. However, given your desire to stay local and not travel, if you're willing to accept that, that's part of the shared decision-making that really has to go into that. In the community setting, you have less access to that multidisciplinary team, so you're not having a regular tumor board with the other providers, and so it is a little bit more fragmented care, as well as your coordination with the radiation colleagues. It's less easy to just send them a quick EMR message and saying, hey, can you see this patient tomorrow, that sort of thing. And then finally, the patient adherence can be a little bit difficult. In the community setting, we'll often have patients with sort of less resources, less medical literacy, and so have to really hammer in the idea that we need to stay on top of this because there's a chance for recurrence. So a kind of quick overview of kind of practical solutions that have built in the community, building pathways with the radiation and the medical oncology teams. And what's I found is a little bit different as I'm doing this in community is that when I was in academics, there might have been 3 or 4, radiation or medical oncologists that had an interest in doing GU tumors. There might just be one in your community that likes that. And so finding that pathway, setting up meetings with them and saying, will you be a partner with me on this? And let's sit down and work on how we're going to do this together. A second one is finding a way to do, multidisciplinary tumor board. In places where things are spread out, it might be a virtual tumor board. So, for example, I join a virtual tumor board with a hospital that's an academic affiliation, but can submit cases to that, on an as-needed basis. There's some great experience, I think, in the music registry from Michigan with virtual tumor boards. And I know when I was a fellow at Sloan Kettering, there were some hospitals that could submit cases to our tumor boards. So these are kind of, especially in the post-COVID era where everyone's comfortable with Teams and Zoom, these are ways that you can really access the multidisciplinary care that may not be easy easy to get otherwise. And then finally, standardizing your protocols to streamline care. And so this is where, meeting with the medical oncologist, your radiation oncologist, and setting up sort of checklists and surveillance protocols so that everyone is on the same page. And because you might not be communicating day to day like you would be in a big center, but making sure that everyone sort of knows what the plan is and help keep the patients, on the right track. And so for the last minute or so, I want to sort of switch focus a little bit, as the community urologist, from the community urologist that's doing trimodal therapy, but also thinking about, in the community as someone who's going to refer a patient out for trimodal therapy to an academic center or a tertiary center. And so the things to think about are your TURBT quality. So really, if this might be a patient that you think is going to want, radiation, really pushing, to do the complete TURBT up front. In addition, maybe considering random biopsies if anything looks like there might be CIS, and very well documenting kind of the complete resection, the size of the tumor, all of that. Just because if that patient is being referred to someone else, they're going to have all these questions, and if it's not clear in the operative report, it may sort of break up how the care is streamlined. And also setting those expectations, so talking to the patient before referral about, they may have this option to do, trimodal therapy and not jump right to cystectomy. So the patient, at least has had time to think about that. And also telling them that, we'll do surveillance afterwards with scopes. There will be an option for salvage treatments, that sort of thing. And then finally, sort of establish the relationships with your partners that might be, able to do these trimodal treatments. And that way, by establishing those relationships, can get patients in quicker, can sort of help streamline the transition back to maybe the community for surveillance or however that is set up. And then kind of looking forward to the future, what's going to change? We're getting more of these biomarker selections, so assays and things like ctDNA that were previously available, only under trials in academic settings. Those are now going to be commercially available in the community, and so those may be able to help us decide who gets, who may be more or less appropriate for certain treatments. We're also going to have new combination, treatments with radiation and different systemic therapies, which we've heard about a lot today. And then finally, just our improvements in surveillance, using some of those, ctDNA markers, other urinary markers that'll help us, figure out who may be having a recurrence. So that's all I got. Thank you very much for your attention.
Thank you, Dr. Haywood. All right, we're going to move on to the case discussion. I think this is the most fun and the critical because, as we know, many of these cases require a multi-D discussion. And I tried to pick a couple of cases from my practice and just kind of have almost like a tumor board discussion and get people to weigh in, including everyone from the audience. Ask questions, suggestions, what would you do? So if we can pull up case 1, please. Oh, I have the clicker. Great. All right, we have a 65-year-old male, pretty healthy, presenting to your clinic with painless gross hematuria. He's got a 10-pound weight loss over the past 2 months that he's noted that has been unintentional. He's passing clots, referred for an urgent cystoscopy and imaging to you. He does have smoking history. Important in terms of lab values, his creatinine clearance is 78. Hemoglobin is 11.2, slightly down because of hematuria. LFTs are all normal. He was a smoker in the past, but he's no longer a smoker. He has no diabetes. His only history is hypertension and BPH. So you have a large tumor on cystoscopy, and the TURBT is showing he's got muscle-invasive bladder cancer. Unfortunately, his CT and PET is showing that he's got, in addition to extravesical extension, which you noted on your TURBT, he also has multiple FDG-avid retroperitoneal lymph nodes measuring up to 2.6 centimeters. And these are retroperitoneal, so outside the pelvis. So he's metastatic. He's de novo metastatic urothelial carcinoma. So as expected, patient did start infirtumab, pembrolizumab, has had multiple cycles of EV-pembro. Part of this is also once he sees a urologist diagnosed with metastatic, he is in the hands of medical oncologist. He has been treated by medical oncologists for multiple cycles, and started developing some of these toxicities around cycle 6 and 7. So it started with some sensory neuropathy, progressed to some gait instability, and started having some grade 2 transaminitis, right? And this is where the urologist gets plugged back in because he's no longer able to really tolerate systemic therapy. And the question is, what can you do as a urologist in this setting? The patient cannot get any more systemic treatment. Going to ctDNA, we are lucky that we're able to track his ctDNA through treatment. So he started with, as you can see up there, 1.2. And depending on people's practice, some do it every 3 months, some do it every 6 to 8 weeks. He has been getting pretty routine ctDNA testing. So it did go down from 1.2 baseline to 0.03 by cycle 7. So it is still slightly positive below the threshold, but it is not 0, as we would say it is, right? So question for the tumor board and for the audience. What is the most appropriate next step in this patient? So you have a 65 metastatic, received EVP, systemic toxicity, ctDNA declined, local disease control. He's got imaging showing MRI that has persistent extravesical thickening on the MRI. He can no longer tolerate systemic therapy. So I'd like to hear from the audience. We're going to do a poll. If you can go ahead and switch it back on, and we'll do a poll to see what you guys would do. So would you resume EV at reduced dose, switch to just maintenance, pembro, refer for multi-D for potential cystectomy, or definitive radiation to the bladder, continue ctDNA surveillance? Remember, MRI is just showing thickening, fibrosis, potential tumor. However, no lymphadenopathy as previously noted on PET-CT. Let's see what people will pick. Okay, well, this is a room of urologists, so not surprised. So I want to hear a little bit about what our tumor board multi-D would actually offer the patient. So we can start with Dr. Calloway. If this is a patient that you've seen in your clinic presenting with declining ctDNA, MRI is showing thickening fibrosis at the previous tumor site, no lymphadenopathy, patient's obviously very healthy. What would your discussion with the patient be?
Yeah, I mean, that's always a hard discussion because you don't really know what you're going to find in that situation, but it's all in the context of systemic therapy. Frontline systemic therapy is impossible and likely will be impossible for him going forward. And then you have to say, well, what else could you do systemically? And those results with, chemotherapy, and would he be a candidate for that? So I do think in these, rare situations of nodal-only disease, even though this is a little higher up, that localized therapy based on, obviously those images that we can't see does make sense. And which one to choose, I don't think we know that, but the benefit of doing a surgical approach, if really fit, is the fact that you get correlation with pathology to know exactly what those changes you allude to are. So I think that is what our de facto has been, just because we get that pathologic comparison at the time of surgery.
Dr. Haywood, would you consider doing anything else for this patient? Do you routinely do cystoscopies or bladder biopsies in these patients when you're considering potential radiation versus cystectomy?
You certainly could. I think where I would struggle is I don't know how much that's going to change what I do. If you do a bladder biopsy or you do a cystoscopy, those are always very difficult to know. Like, is that clinical T0 or the true path T0, like we talked about? And then it's going to be hard if you do a bladder biopsy to know, does that really represent everything that you see? So I don't know that I would do a ton else besides, no more workup, I guess. I think it'd be reasonable to consider the consolidated cystectomy as the group is leading towards. There's a lot of shared decision making in there with the patient of knowing that they may not necessarily benefit from it, but at least allows you a pathway off of systemic therapy that seems like is going to be prohibitive moving forward.
And when you have the discussion with this patient's previously metastatic, high risk, right? Would you offer them a neobladder, or would you be hesitant to offer someone like this a neobladder?
I'd probably be hesitant. I think I don't have a good answer for why, I guess, if I'm being completely honest, but it would just, would make me a little bit nervous, especially you don't know how the disease course is going to go. Are they going to need more treatments down the road? It would certainly make me hesitant, but I can't think of a reason why I could tell them no, honestly.
I'm curious, by show of hands, who would offer a neobladder for this patient? Who would offer a conduit? Okay, great. Dr. Shalini, what would you offer in terms of radiation to the patient? And then what would you need anything else in terms of imaging or evaluation before you would mention that he's eligible for radiation?
I think this is a tricky question purely because of the systemic therapy question as well. So one thought is we want to consider concurrent chemo, if at all possible. And then the other thing that I would also consider is getting an MRI. A lot of times that gives us a better idea of where this residual disease is. It could be fibrosis versus active disease. A repeat, biopsy and cysto will help as well. But I think MRI imaging is super helpful in this situation if we would consider consolidative radiation treatment. And the fractionation and dose would be similar to what we had just talked about earlier in the session. There wouldn't necessarily be like a higher dose per se to the bladder, but it would primarily be to get an idea of the degree of residual disease left.
So a patient did undergo robotic cystectomy. He did want a neobladder, even though we did talk about the fibrosis, a potential high risk of complications, particularly post-treatment. He had a pretty uncomplicated course. His final pathology, as you can see here, was T1. The original MRI, as we mentioned, actually was concerning for T3 disease, right? And that's a limitation we have with imaging, particularly in locally advanced disease. The MRI, even when there's fibrosis, it's difficult to say if that's cancer or if that's fibrosis. We're going to move on for the sake of time, as we do have another case. However, his post-op ctDNA was 0. So this is a great example of a patient who just has T1 disease, right? You would not expect this to continuously shed. However, post-cystectomy with T1 disease, his ctDNA did become 0. So that's interesting. We're finding all of these interesting details about what MRD testing is, even in the non-muscle invasive space like this patient. Even with residual T1 disease, he still had shedding of his tumor. Do you have any comments?
So, as expected, I'll give a little bit of a systemic comment rather than the local comments that have been astutely addressed. Starting off with the presentation, something would have had to gone really wrong in the patient's follow-up for him to develop grade 3 disease, grade 3 neuropathy right at that level. Usually at grade 1 and 2, we're already talking about dropping the EV dose, and these discussions happen a lot sooner. Even in the EV302 study, the grade 3 neuropathy was actually lower than cisplatin and Gemzar because of early dose interruptions and so forth. So hopefully in practice, patients are not getting to grade 3 neuropathy, which is distinct from other grade 3 toxins, can be a lot more morbid. Secondly, I'm curious what happened to the retroperitoneal lymph node. Like I'm seeing above the pelvis, right? So that would be my concern. So I chose probably a couple of these options. I first chose using pembrolizumab monotherapy to kind of gauge, is the ctDNA clearance driven by the EV, and now that you're taking away the EV, is that going to go right back up? And the retroperitoneal lymph node is going to be a site of progression. I think that tincture of time sometimes helps, where that ctDNA clearance is coming from. Is it IO-related, durable, versus EV-driven, and when you stop the EV, it's going to go right back up? I think that's an unknown question. And then the third point would be the ctDNA clearance. I think absolutely we have seen some ctDNA clearance even from cystectomy in the Niagara trial, even across both arms. So there is a small subset of patients, even with localized disease, that have shedding systemically, and cystectomy can have a role in clearing that. I would just add that I think we are at the early stages of ctDNA assessment. So right now we are at a detection threshold of 1 in 100 or 1 in 1,000 for some. There are whole genome-based assays and new technologies. And I think we should take that into the context of greater disease before becoming too comfortable with ctDNA negativity, because that negativity is driven by what our threshold of detection is.
That comment. So we're going to ask, what is the appropriate next adjuvant treatment? So patient has had a cystectomy, residual T1 and 0, PET-CT negative for the retroperitoneal node in terms of your comment. We did not think that an RP-D was necessary in this patient. So what would you choose as an adjuvant treatment for this patient? Would you resume Pembro? Would you resume both EV and Pembro? Would you just observe with scans? Would you observe with scans and then potentially ctDNA, and then really reserving Pembro if you have any radiographic or potential ctDNA bump? This is an opinion question, I think. Yeah, so I think glad to see that 80% are at least same opinion. So, so observation with DNA and CT. Question to you. Let's say this patient does have ctDNA bump. Would that ever be enough for you to continue restarting Pembro, or do you always wait for radiographic evidence?
Yes, that's a great question. I think I would like to see where that ctDNA bump is coming from. More than likely it's coming from that retroperitoneal lymph node. He's still M1A, and so I would probably treat him as a metastatic disease patient because we haven't addressed that retroperitoneal lymph node through local therapy. I would actually, I would consider local therapy to that lymph node. I think perhaps not with our RP-D, but with our radon colleagues, MET-directed radiation, we've been able to do SBRT and have had some good success with converting some of those early ctDNA positive patients to negative with local therapy. So I think a couple of these different options in combination could work. The re-challenge of EV depends on how, what the status of neuropathy is in that setting. It would be great if the patient comes back to grade 1 levels, and you can make an argument of dose reduction and intermittent EV for that case to make it tolerable for the patients. But I would probably try to see where that ctDNA shedding might be coming from and treat that.
Very, very reasonable. And we do have patients where they do have recurrence in the retroperitoneum that was originally not PET-avid, but have been addressed by a radiation colleague. So we'll move on to the second case. Can we pull up the second case? Any comments from the audience regarding questions, comments, things you would have done differently? Would anyone offer potential radiation up front to the node and the bladder? Show of hands. Nope. You? I might. No problem. No problem. Thank you. All righty. So locally advanced and a complex transplant patient. This is our Cleveland Clinic special. So 69-year-old male presents to your office as a referral from the community with his wife complaining of severe back pain and fatigue. He's recently had a TURBT already and had bilateral stents placed for what sounds like he was told something blocking it. His baseline level of creatinine is 1.3, 1.4. He's now here with a creatinine of 3.29 in your office. He looks frail. He looks sick. He's got a history of pulmonary fibrosis that actually received a bilateral lung transplant 5 years ago, and he's been stable on his immunosuppression. So he's had a TURBT in an outside hospital, which reveals that he's got invasive high-grade with micropapillary features. You do have imaging that shows he's got bilateral stents and hydro around the stents, This is just a cross-cut showing that he's got hydro. And then he did get an MRI. This is CT. Oh, it's playing great. So he's got a CT. You see that the stents are failing, secondary to obstruction. And if you look at we'll look at the MRI. Can you play that? Or just play? There you go. This is the MRI that you see. You see diffuse thickening. The MRI radiologist is calling this a diffuse bladder thickening invasion of the adjacent structures, compatible with clinical T4 cancer. However, no lymph nodes. He's also had chest imaging and abdominal imaging showing no lymphadenopathy. So you admit the patient for percutaneous nephrostomy tube placement. You decompress the patient, and the question is, what do you do next? Do you proceed directly to upfront radical cystectomy? He is very sick. He's got clinical decline. He's not eligible for many therapies because of his transplant. Do you start EVP, accepting the risk of potential rejection of his transplant? Do you EV only, or do you potentially try gem-carbo reduced dose, despite renal impairment, hoping that the percutaneous tubes will help with his creatinine function? So going to the poll. Difficult patient, but a real-world scenario. And remember, he is micropapillary. Okay, move on. Oh, wow. Directly to cystectomy. 44%. So no one said EVP, EV monotherapy, and some said gem-carbo. I'm curious what you think.
So this case reminds me, or gives me PTSD from last month, where we had the same case, but with allo transplant for BMT, complicated by GVHD. So very similar clinical scenario. And immune-mediated pneumonitis from GVHD, so kind of exactly the same. I think the challenge thing here is that to understand the relative risk of, I would say, systemic therapy and local therapy, both of them, I would actually have a discussion with the urologist to begin with and the patient what the perioperative mortality is, considering all of these factors, the pneumonitis and all that, and see if we are getting towards a definitive local therapies that's safe. And if that's the case, then I think we got to start working towards what systemic therapy we can give to get the patient in the best shape possible for curative intent treatment. Choices are obviously challenging. You can't give the patient cisplatin-based therapy. I think there is very little data in the carboplatin space, and we really don't have much to go off on. In this case, I think EV monotherapy would probably be the best option to get some downstaging done. We have data from single-arm cohorts of EV103 study, and I believe the cohort H, that actually use EV monotherapy in patients with muscle-invasive bladder cancer who are ineligible for cisplatin. And it showed the pathologic complete response rate, I believe, of around 35-36%. So it is quite active. We don't have long-term durability data, but I think considering the locally advanced disease, I think it's a very rational treatment.
Dr. Haywood, if this patient was in your office, what would you offer this patient and why?
Probably refer to an academic center, but no. In all honesty, I think I'd probably go with choice A of the upfront radical cystectomy. I think what's hard, at least what I'm thinking, is I can't imagine that his bladder function is very good from that MRI,
But he's diverted now with tubes.
Diverted now, right? But I'm going to guess that this patient doesn't care for them, and so I think that even if the discussion I would have with them is I don't know that this is, it probably won't be curative, but I at least offers us the best upfront option. We get very good pathology. We're able to do a urinary diversion where theoretically your kidneys won't be obstructed. We can maximize your renal function, and then try our best in the future with a systemic therapy. And I guess even could, if you have positive margins, could consider some adjuvant radiation therapy as well.
Dr. Shalini, would you offer this patient any kind of radiation before or after?
I wouldn't before, but I would consider it after. I think we could consider it in the post-op setting. My concern with offering it up front is the limited options for concurrent treatment.
In
along
terms
with
of
radiation.
chemo?
Mm-hmm. Yep.
Okay.
So.
All right, we're going to move on. So patient did get EV. He initiated EV monotherapy, completed 3 cycles, very well tolerated for the patient. He got a ctDNA post-cycle 3 that showed 0, surprisingly. His post-cycle 3 ctDNA and his MRI, let's see if this is working. So this is his post-treatment MRI, shows great response. But the MRI does show these sort of residual nodules, right? And they're calling this residual tumor. Patient was able to remove his percutaneous tubes, really minimal hydro, but MRI again is showing some residual disease. So Dr. Calloway, at this point, patient is in your clinic. What would you say are next steps?
Yeah, I mean, in this situation, as long as he is a surgical candidate, he is down that course, both to get him unobstructed and to get rid of those tubes, and because that is part of the disease paradigm.
And how long do you wait between his EV without the P and offering surgery? Is it a couple weeks?
Yeah, I think traditionally for cisplatin, it's 6 weeks because they have to recover blood counts and others. I think after EV Pembro, we can operate a little bit sooner in that patient population. For the most part, they're not as well taxed as our chemotherapy population, so 4 to 6 weeks.
4 to 6 weeks. Right. So we talked about this. What would everyone else do? Would you continue EV until there's absolutely nothing on the MRI? Would you consider radiation therapy to the bladder? Or would you consider surgery at this point? So again, patient previously locally advanced, non-metastatic, micropapillary, 3 cycles of EV therapy, had good response on MRI and ctDNA negative. He is a bilateral lung transplant patient. So he is a sick patient. He's looking better even after just 3 cycles. So it looks like cystectomy. For the sake of time, we'll move on. He did undergo cystectomy, and his final pathology is T0 despite the MRI findings of nodularity. So no residual cancer, incidental prostate cancer. So it's curative intent in both bladder and in prostate. However, negative for any urothelial or for micropapillary component. So again, what do we do after this? What do we do for this?
I'd probably take the success we've had so far and run with it. So I'd probably continue observation with ctDNA and radiographic surveillance. Lung transplant patients tend to be on a lot of immunosuppression, and you don't want to give it more chance to have, secondary infectious complications. So whatever we can get away with, I think that's probably the best case scenario, especially considering it's ctDNA negative and PAT-CR. We don't know how much the adjuvant component adds in that setting.
I want to change this scenario. What if this patient had T2 disease at the time of cystectomy? Would you consider adding adjuvant radiation for this patient with micropapillary component? No micropap on the final path, just urothelial.
T2 and then N0.
N0, resection R0.
I think it's tricky. At this point, we're saving it for really aggressive patients. So there could be a hybrid approach where we watch the ctDNA and then potentially consider adjuvant after there's like a little bit of a spike in ctDNA.
Okay. And if you do offer surveillance, how often? What would your surveillance in him be, Dr. Haywood? Would you consider just imaging, ctDNA? What is your choice of surveillance?
I think, at a minimum, I would do imaging. If ctDNA is possible in your practice setting, I'd probably do that as well.
Okay. So curious what everyone else would do. So would you recommend in this patient, remember T0 at the time of resection, previously micropapillary? Would you consider adjuvant EV, adjuvant pembro, or observation with serial ctDNAs or just radiographic surveillance? Observation. Great. So patient is cured. Thank you so much. Thank you to everyone who attended. I know it's the end of AUA, and thank you to all of our speakers, and we'll see everyone in 2027.